Thank you very much for your kind introduction, and thank you for the organizing committee for inviting me to, and for you audience who stay late with the last session. My topic is HIV and malignancy. I will show you one case of interesting case. A 37-year-old male referred from a provincial hospital with a jaundice and abdominal distension. 6 weeks prior to admission to our hospital, he developed left bowel palsy and treated with prednisolone 60 milligrams per day for 24 days. I think at the beginning they do the HIV test, and then he come back for the follow-up. They show that he have HIV positive, and the CD4 later on is 337 cells, and he was started on TDF, FTC, and efavirenz. 2 weeks later, he developed jaundice and admitted into that hospital. He has a history of heavy alcohol drinking. And this is the lab from the local hospital. Liver function test, total bilirubin up to 18.2, and direct bilirubin is 16. ALT 139, AST 104, alkali phosphatase 1,492, creatinine rising from 1 to 6. And the ultrasound showed that dilated intrahepatic duct in both lobes with infiltration lesion at the porta hepatis, bilateral hydronephrosis. And his hepatitis B showed that he already have immune hepatitis C negative, hepatitis A negative, and serum cryptoantigen negative, PDRL non-reactive, and the CD4 as I already showed you. So this is a physical examination on him. He have febrile white pulse of 100 beat per minute, respiratory rate 20, and blood pressure in the normal range, but he has a marked jaundice and with hepatomegaly, mild tenderness, and no lymphadenopathy, pitting edema, clapping fingers, and flapping tremor, positive. Neuro exam, only left bowel palsy, that's still there. Other neurological examination were normal, and also the stiff neck. And this is the lab in our hospital, the CBC, hemoglobin 11.6, hematocrit 35, white count is leukocytosis 24,000, platelet normal, and PT and INR slightly prolonged to 1.7, and beyond 111, creatinine is 5.6, sodium slightly low, and the bicarb is 16.1. He has acidosis. Calcium is 8.9, magnesium is 2.6, phosphate is 5.9, and uric is 22. Liver function test, albumin 2.9, globulin is 1.8. Total bilirubin increased to 36.5. Direct is 34. ALT 58. AST is 113. Alkali phos up to 2,841. LDH is again very high, 2,900. Alpha fetoprotein is 2.4, that is normal. CEA 1.76 is normal, but CA99 is over 1,000. So this is his chest X-ray. He has a bilateral lung infiltration. And this is the interpretation from the radiologist from his CT abdomen. He have hepatomegaly with mild intrahepatic duct dilatation. Periductal enhancement and cholangitis is suspected. Thick wall gallbladder with pericholecystic fluid and a calculus cholecystitis is suspected. bilateral pyelitis, diffuse fat strand with thickening intra-abdominal fat plain with minimal ascites in right paracolic gutter and pelvic cavity. Infection or inflammation process should be considered. Multiple intra-abdominal lymphadenopathy along with the para-aortic and mesenterics. Bilateral pleural effusion with passive atherectasis. So this is his problem: fever, cholestatic jaundice, pneumonia, acute kidney injury. He has underlying of HIV infection and Bell palsy with steroid treatment in the past. So I would like to ask you, what is the most likely cause of jaundice in this patient? A is a disseminated infection, tuberculosis. B is MAC. C is a fungal infection. D, he has jaundice, a common malignancy in this area, cholangiocarcinoma with cholangitis, or he has an aggressive type of lymphoma. Please vote. So, since we are in the topic of HIV and malignancy, so you don't vote for infection. So most of you select malignancy, and because I'm persuaded that we should consider cholangiocarcinoma. So the most common answer is cholangiocarcinoma, and some of you vote for aggressive lymphoma. Okay. So what is the most, what is the most likely to give diagnosis investigation in this patient? A, sputum for staining, PCR and cultures, and blood culture for many cultures, mycobacterial, bacteria and fungus, liver biopsy, MRCP or bone marrow aspiration. Please vote. Okay, so most of you said that it should be liver biopsy. Interesting. This patient has very severe. He has a kidney problem. He has a very, he has liver enlarged. So we might consider do liver biopsy on this patient. However, since we know that this patient have a very high LDH in the serum, so and he developed the kidney failure. It might be from uric acid from lymph node that cause obstruction or something like that. So in this patient, we consider that he might have some malignancy. So this is an investigation on this patient. He has pneumonia, so we also consider that he might have a co-infection with TB. So we do sputum AFB for 3 days and PCR gene expert as Dr. Kampon suggestion. It's all negative, but sputum PCR for pneumocystis jirovecii is positive. And the sputum culture grew the Klebsiella pneumoniae, carbapenem resistant strain or CRE. We do the bone marrow biopsy and aspiration. The bone marrow show diffuse infiltration of last young lymphoid cell, and diagnosis is Burkitt lymphoma involve bone marrow. So do you think this patient will receive chemotherapy? Will he survive? I do not prepare for voting. Who think he will survive? Some of you very optimistic. Okay, so this is the BUN creatinine along the course. This time, our nephrology do the hemodialysis on him. So you can see the BUN creatinine down for some time, but it's up again. So even we have a diagnosis, but hematologist is reluctant to give chemotherapy with the patient with liver failure and kidney failure. So we just supported him, and this is his chest X-ray has progression of infiltration, and the sputum grand stain show the yeast with budding and pseudomycelium. Sputum culture still grew CRE, Klebsiella pneumoniae, and the urine culture Candida albicans. This is the cause of death in this patient. He has a blood culture grew Candida albicans, and he did not make it. So from this case, I look back to our cases with HIV and lymphoma hospitalized in our hospital 5-year retrospectively. So we identify 28 cases. The median age is about 40 years old. Most of them are male, and the median CD4 count is 222. Half of them is ARV naive. So if you can imagine, some of the patients already on treatment, but half of them are not on the treatment before. And the type of lymphoma most common is the diffuse large B-cell lymphoma, and 5 cases is primary CNS, and Burkitt lymphoma is 4 cases, T-cell 4, and plasmablastic in 3 cases. And the outcome, you can see that surviving in this patient is very low. It's less than 20%. Most of them die during hospital, and some of them discharge home and do not come back for follow-up, or some of them refer out, so we don't know. But I want to show that lymphoma with the hospitalization in our hospital has a very high mortality. This is a common age-defining and non-age-defining tumor that associate with oncogene. You can see that the KS, is associated with the herpes virus type 8, and primary CNS is associated with EBV, and also some Burkitt B-cell, diffuse large B-cell, and other plus primary effusion of lymphoma. Cervical cancer is associated with papilloma virus, and Hodgkin also associated with EBV. Anal cancer, papilloma virus, and hepatocellular carcinoma is hepatitis B and C. Head and neck is papilloma virus and EBV. And this is the assessment of malignancy in HIV patient in EuroCedar. You can divide it into the infection-related malignancy that we already talked to. And the risk factor is age and lower CD4 count, hepatitis B co-infection, detectable viral load. So it means the patient not on treatment, and the prior age-defining malignancy. For the infection-unrelated malignancy, the common one is the cancer, lung cancer, prostate, colorectal, and breast cancer. This is also associated with the age, low CD4 count, hepatitis co-infection, and current smoking. And you all know about the START study. Even the patient have a high CD4 count over 500. Start antiretroviral treatment also reduce the malignancy, especially Kaposi sarcoma, and lymphoma. And this is the Thailand data that the CD4 range in the patient who start antiretroviral treatment. You can see that in the earlier year, the red and the pink one is the CD4 less than 100 or less than 200. 60% of them start antiretroviral at a very low CD4 count, and we are improving recently. And this is the median CD4 count in Thai patients who start antiretroviral treatment. Right now, we go up to about 194 cells. And this is the incident, the standard incident ratio for age-defining cancer before pre-heart era and early heart era. You can see that Kaposi sarcoma and primary CNS lymphoma markedly reduced, but for other malignancy like Burkitt or diffuse large B cell or other non-Hodgkin lymphoma, the effect is not very clear. And this is for non-age defining cancer. You can see some of the cancer increasing after heart use. Okay? And if you compare HIV infection to non-HIV infection, you can see that the anal cancer is much higher in HIV infected patient, and Hodgkin lymphoma, and also oral and pharyngeal carcinoma is higher in non-HIV infection. And a lot of malignancy, anal, Hodgkin lymphoma, and oral pharyngeal lymphoma is related to the level of the CD4. You can see that if the CD4 is less than 200, the incidence is very high as compared to 500 cells. So this is a P significant. And this is show the predictor of the cancer incidence in heart. This is one of the study from the cynics observational. You can see that KS and lymphoma is markedly reduced after antiretroviral treatment, and it stay very low. But for other non-KS and non-lymphoma, it seems to be increased in this cohort. Okay, but in the DAD study, when they look at the non-AIDS malignancy overall, the incidence seems to be stable. However, among HIV patients, non-AIDS defining malignancy that is common is lung, anal, and Hodgkin lymphoma. For cancer prevention, if you can do, one of the most effective thing to do is let your patients stop smoking, which is very difficult for me. We can ask them to take medication every day. They can do it, but when they come to the clinic, in their pocket, they have a cigarette in their pocket every time. So even I try to tell them that you should stop smoking. Is very difficult, but it's very effective way to reduce the risk of malignancy. Provide the hepatitis and papilloma virus vaccination. Advised to use sunscreen or avoid sun exposure. This is for Western country. Screening yearly for cervical and anal prep as indicate. Colon cancer screening at age of 50. Breast cancer screening every other year at the age of 50. Prostate screening should be discussed at age of 50. So, and hepatitis B and C positive, you should screen for liver cancer. So we now taking care of more aging patient. A lot of our patient is over 50, so we have to talk about the malignancy in this patient. This is the summary, the screening of the cancer that we mentioned. Anal cancer in the risk group is MSM, so you should do the PR or the pap smear test, but the evidence that it is reduce the mortality is unknown, but most of the experts also recommend to do the screening. For breast cancer, women over 50 years old to do the mammogram. This reduces the mortality. Cervical cancer, sexually active women should do pap smear every year. This is also reduced mortality. Colorectal, 50 years old up, so you should do the occult blood in the stool or the colonoscope. This is again reduced mortality. For hepatoma, in the patient who have cirrhosis from hepatitis B, or in our region, hepatitis C, also the problem. So you should do the ultrasound and alpha fetoprotein. This improve ability to do the surgical correction, so may reduce mortality. And the last one is a prostate cancer in the men who age over 50. You should do the PR and PSA. And one of the screening that we do not do the routinely, this study show that the screening with the low-dose CT scan of the lung in high-risk patient. In the US, they enroll patients over 50,000 cases who have a high risk of lung cancer to do the low-dose CT scan with the routine chest X-ray. From this graph, you can see that low-dose CT scan can detect early lung cancer than routine chest X-ray. And the lower graph is the cumulative of lung cancer death, that is the mortality. You can see that if you use the low-dose CT scan, you may reduce the mortality in this high-risk group. So in the USPSTF recommend the annual low-dose CT scan in the patient who age 55 to 80 who have 30 packed year of smoking history and currently smoking or quit smoking within the past 15 years to reduce the mortality. Okay, and this is my summary slide. I show you that the age-defining malignancy mostly related to oncogenic virus. Some of the virus we cannot do anything, but for some of the virus we have vaccine. The incidence of age-defining malignancy is correlated to the antiretroviral use and the CD4 level. So again, this is encourage everyone to, this is one of the topic we can discuss with the patient who have HIV positive and reluctant to start antiretroviral. We can reduce malignancy. So most of the people are very scared of malignancy. Common non-AIDS malignancy are lung, anal cancer, Hodgkin lymphoma. For prevention, you should start antiretroviral very early, smoking cessation, hepatitis and papilloma, human papilloma virus vaccination, and screening for cancer among high-risk group. Thank you very much for your attention.